co-chairs of the Northern Michigan Council of the National Multiple Sclerosis Society. And before we get too far into the program, I have a number of thank yous to give. And I think the first thank you needs to go to Traverse Area District Library and Melissa. Thank you so much. They have been wonderful hosts to our program and great partners here in the community. So thank you, Melissa. I'd also like to thank Kim Elmquist. Kim works in the Community Outreach Department at Bunsen Medical Center. And once we were able to contact, she has been interested in our MS Society. And so we get to partner through Kim for the presentation tonight as well. And then I would also like to thank a number of folks here from the MS Society that are here tonight. It's not just Patty and I, but we also have Tammy Willis in the orange in the back. And Tammy is director here from Michigan. And she has been a wonderful kind of kick in the pants every once in a while to help us really improve our Northern Michigan chapter here in a couple of years. So that is lovely. And then I would also be remiss if I didn't say hello, and I'm sorry, I'm having so embarrassing. Please, Sherry Fenton, also a board member for our Board of Trustees for the state of Michigan. Sorry for the name blank, Sherry. That'll be the last one of the day. So Patty and I are here because MS came into our family. Comes into people's lives that you love and changes those lives. So with that heartbreak of one of our sons being diagnosed, we've tried to change that into something a little more positive. So we've done some fundraising through wonderful bike MS events, and then we were tapped by Tammy to try and get our chapter in Northern Michigan going, which we've done. So we're very happy about that. So tonight's agenda, we're going to start off with Dr. Walch. She's going to discuss the new diagnostic criteria in MS. Dr. Austin here from Munson will also be talking about some new things in neurology in Northern Michigan with Munson. And then Jenna Stoddard, nurse practitioner, is here from Novella to talk about her role and the role of nurse practitioners in their practice. So we're extremely grateful to have each and every one here to give us a little Northern Michigan perspective. So let's start with Dr. Walch. She is a product of Michigan State University. Gained her education there, and got her doctorate in osteopathy there at MSU. Also a neurology residency at Ascension System in Detroit. Followed that with a MS and neuroimmunology fellowship at the University of Cincinnati at the Waddell Center for MS. She's also on our Board of Trustees here for the MS Society and really is one of the folks who is driving research in America along with her research colleagues in MS. So we are extremely happy to have Dr. Walch talk about a bit of a sea change in the diagnosis of multiple sclerosis. So Dr. Walch, thank you very much for being here. The floor is yours.
All right, thank you.
You're very welcome.
Hello. Wow, that's loud. Thank you all for having me. It's always lovely to come up to Traverse City, one of my favorite places, having spent a lot of my summers up here, and my parents lived in Interlaken. So today, I actually get the pleasure of talking about multiple sclerosis, and then just recently, we had new criteria published called the McDonald's Criteria, an update in 2024, and how that is changing how we diagnose multiple sclerosis. So really kind of very open conversation. I'm going to level set us all. So we're not going to jump right into the McDonald's criteria. We're going to level set. So today we're going to talk about what is multiple sclerosis. I have my own analogies that I use that we will bring back throughout this entire presentation, and also talk about the different types of multiple sclerosis that there are. People always come to me, what type of multiple sclerosis do I have? What does that look like for the future? What does it look like for my treatment options? And understanding how we as clinicians arrive at certain diagnoses helps you as patients better understand our treatment goals and allows for a better clinician-patient relationship. What are the McDonald's criteria? Why do we use it? And how is MS diagnosed with MRIs and even other paraclinical data? So let's start off with what is multiple sclerosis? So multiple sclerosis is an autoimmune disease in which your immune system mistakenly attacks your optic nerve, which controls vision, your brain, and your spinal cord. And what it actually does is it attacks this thing called myelin, which is this sheath that helps propagate or send the information going faster. And then it can also attack the axons, which are the part of the nerve that transmit the information. It can also attack the oligodendrocytes. We have some weird words in neurology. But oligodendrocytes are the cells that make that covering. And so over here in this picture from the National MS Society, we see what a normal nerve looks like. And you see those sheaths, those myelin sheaths of myelin sheaths wrapping the axon of the nerve. And that's what smooth transmission looks like. What happens in things like multiple sclerosis is that myelin sheath gets damaged, and sometimes even underneath that myelin sheath gets damaged, the axons get damaged. Now, when I'm in the office with patients, I actually compare this to Michigan roads. So what the brain and the spinal cord start off as is a beautifully paved highway. And what MS inflammatory status does is comes through and chops potholes in there. And sometimes you can weave around those potholes, and sometimes you can't. They're in really big spots. What can happen is underneath the pothole, we have all that concrete or cement. I'm never sure if it's concrete or cement, but that concrete underneath, and that can also degrade. And so those are the axons down there. And so we have different things that are happening simultaneously in different forms of MS that are either creating more potholes or creating more damage to the concrete underneath. Now, protecting that concrete underneath is incredibly important. So things that we know do damage is smoking and not enough vitamin D, and exercise helps protect that concrete. So when you're looking to be empowered about what you can do to protect yourself from concrete damage or axonal damage, it's make sure you get enough vitamin D, make sure you don't smoke, and exercise. Any questions about my weird analogy? So then let's also talk about types of multiple sclerosis. So there are really two flavors of multiple sclerosis. There's what starts as relapsing remitting multiple sclerosis. This is the most common form of MS, and this is the one that forms all those potholes. And you have a pothole form, and then you're okay for a while in between, and then you might have another pothole form. Many years later, and the number of years later is dependent on the person and multiple other things, it develops into what's called a secondary progressive form of MS, which is more of that concrete underneath falling apart, those axons falling apart. And so you see from this picture down here, this is an older picture, an infographic, but it actually helps define what happens in relapsing remitting MS, and then what happens followed by a secondary progressive MS. So this, on this side, the vertical here, is disability. Problems walking, problems using hands, fine motor movements, coordination. And so we see that after a relapsing remitting phase, people can go into a progressive phase. And that's dependent on a lot of things. Other types of MS present much more slowly and over the course of a year or more with progressive problems with things like walking, hand motions, and just not doing real well over that past 12 to 24 months. And so one of the kickers on this history is there is not a clear defined event that you can say, in August of 2023, all of a sudden I couldn't walk. It's like 2 years ago I was struggling on vacation, and then the next winter I couldn't ski, and then I couldn't run the marathon or the 5K, or I couldn't do something else in that summer. And it's just those kind of things. Oh, I thought I was just getting old. I thought my joints just hurt. And we see that it's just kind of slow over those months to weeks to years at a time. So those are the types of MS that we now are left with diagnosing. So we've got relapsing remitting, secondary progressive that happens after the relapsing remitting phase. And to make it even more confusing, we've got active secondary progressive and non-active secondary progressive. And then you've got primary progressive MS. And as our research advances, understanding where a person is in their state of MS is going to help drive what the right treatment options are for that person. We have over 20 medications currently to treat multiple sclerosis, with many more in the pipeline. So it's really shifted in this century on how we treat MS. So other terms that have been previously used that are actually starting to fall out of favor, but if you have lived and thrived with MS for many years now, you've probably heard some of these terms. There's clinically isolated syndrome, and that is one event that is suggestive of an inflammatory process, demyelination, which means literally pulling that myelin off those nerves or forming those potholes. And those are classic, what we call classic events of optic neuritis, which is vision loss typically in one eye. Sometimes it's a grain in the central part of the vision. Some people will say they feel like their contact has something on it, that smudgy sensation, and there's pain with eye movement. So that's a typical presentation of optic neuritis. Double vision is also very common because you can't move the eyes together due to a lesion that happens in the back part of the brain that controls the nerves that move your eye. And then also something called transverse myelitis, which is damage in the spinal cord that can cause either sensory symptoms, so like numbness and tingling, or painful numbness, or loss or decreased function in an arm or a leg. Can also be associated sometimes with some of the bowel and bladder symptoms we see in multiple sclerosis. So clinically isolated syndrome was the term we previously used for one event but did not meet the diagnostic criteria for multiple sclerosis. And that is some of what the 2024 McDonald's criteria sought to help change. And then another syndrome that we used commonly was called radiographic isolated syndrome. So this means that we see changes on somebody's MRI that are consistent with things that look like multiple sclerosis or consistent with multiple sclerosis, but they've never had a symptom. Oftentimes that MRI is done for another reason. Somebody was in a car accident. Somebody has really bad headaches. Those are the two most common things that I see. And then we discover this kind of incidentally, and it's now what we've deemed a great time to intervene before they have any symptoms. And that's another thing that this newest update to McDonald's criteria helped us diagnose MS in that patient earlier instead of waiting and letting something happen. So what are the McDonald's criteria? I've been alluding to them here earlier, but McDonald's criteria are guidelines that we as neurologists and other healthcare clinicians use to accurately diagnose multiple sclerosis. The first set of guidelines for McDonald's criteria specifically were available in 2001. The average time to an MS diagnosis then was about 4 years. With the 2017, we started to see that number, the 2017 McDonald's criteria, we started to see that time frame to diagnosis decrease to closer to a year. So that's really good in the course of 15 to 20 years in medicine. Really, really impressive. But the goal is still, how do we accurately diagnose MS earlier and intervene earlier? And so we use these criteria to help us differentiate it between other conditions that can look like MS. There are other things that can leave white spots in the brain that we saw and we'll see on some MRIs. And so we need to be conscientious when we make this diagnosis and make the right diagnosis for the patient. So how do I use McDonald's criteria in my clinic? I use it to use somebody's clinical history, what they come and tell me has been going on, and then I also use what's called paraclinical data. And that's the really fancy term for all of the testing that doctors like me make you go through when you come to my office with possible MS. So paraclinical data are things like MRIs, a lumbar puncture, special eye tests. So there's eye tests that actually can take a picture of the back of your eye. It's called an optical coherence test and tell me how thick that nerve is back there. There's also another test called a visual evoked potential, and that tells me how fast information is going through that optic nerve. And then I also listen to somebody's clinical history. This is why I don't think AI will ever be able to replace somebody like me, because trying to pull out all of that information on what is that history, what are you coming in, what event did you have, and what symptoms are you having from that? And just to make neurology a little bit harder, you can have numbness and tingling from a problem in your brain, a problem in your spinal cord, a problem in your nerves. And so it's my job then to tell, is the problem actually coming from the brain and the spinal cord, or is the problem outside of those areas and it's coming from the nerves? And that's where we really have to dig in and make sure that we're diagnosing appropriately. So McDonald's criteria use two terms that we're going to chat about called dissemination in space and dissemination in time. Very big words to basically say dissemination in space means more than one lesion in more than one place. And that's because I want to make sure that whatever I'm calling MS is truly MS. So I look, and I actually will show you guys a couple of pictures of some classic MS MRIs. I look for where is the evidence of inflammation on that MRI. Is it in that optic nerve that can cause problems with your vision, with that grain or that painful eye movement? Is it in the brain in very classic locations? So is it right up next to what we call the ventricle, which is an area that houses fluid inside your brain? Is it cortical, juxtacortical, which is on the outside part of your brain? Is it in what we call the lower part of your brain, the brainstem and the cerebellum? So the brainstem is what controls your cranial nerves in your face, and your cerebellum controls some of that coordination and smoothness of motion. And a lot of that takes big freeways of nerves, and that's why potholes like to form in those areas. And then also in the spinal cord. So to meet dissemination in space, you have to have at least lesions in two classic places. And if you have lesions in 3 or 4, that's even more suggestive of multiple sclerosis. And that helps us get to that diagnosis earlier and allow for treatment earlier. And then dissemination in time. Dissemination in time means that things are separated and occur more than once. And you could, in the 2017 guidelines, you could fulfill dissemination in time a couple different ways. You could have 2 different clinical events. You could have one event of loss of vision, recover 2 years later, have numbness and tingling of your right arm, and that would meet those criteria for dissemination in time. You could also, on your MRI, have one active or GAD-enhancing lesion, that contrast that some people give when patients get MRIs with their MS, and you can have a non-active lesion. So if a lesion is GAD-enhancing, it typically means that that is new within the past 4 weeks. That's also why there's been a big shift for some of you who've been in MS for a while now to getting your MRIs without contrast, because I care if there are any new lesions. So I look at them year to year for new lesions, and if it doesn't enhance and there's still a new lesion, I'm equally concerned as if it were an enhancing lesion. And then a lumbar puncture in the 2017 guidelines could also be used to fulfill those criteria of that dissemination in time. Dissemination in time in the new criteria is not definitively needed if you have classic MRI findings and a classic history. So this is the one shift of hoping to get that diagnosis correct and earlier, to initiate treatment earlier. Although you will probably still hear all of your clinicians kind of look at all of this stuff. I don't think anybody's quite ready to give this up. But officially, it's fading out. So how many of you with MS, I guess you don't have to raise your hands, but do people show you your MRIs? I think it's good for people to see their own MRIs and see them from time to time, absolutely. So here are a couple different pictures of MRIs of very classic looking MS lesions. So we've got over here in this first one, and this one happened to have pretty yellow arrows, which made my job super easy. But these are ovoid white matter spots. So they're what we call T2 hyperintense, is what you might see on your radiology report, because all of you can now see them through your portal, sometimes at exactly the same time I get it. Sometimes even before I've gotten to see it. But T2 hyperintensities is what we call those, or bright white spots with multiple sclerosis. And then we have over here on the middle diagram, also with arrows, these are ones that are what we call cortical and juxtacortical. So they're kind of on the outside of the brain here, towards the edge of where those fibers are. So that's what somebody else means when they say, are these lesions juxtacortical, cortical? You might also see abbreviations like JC/C in reports. And then over on the far side, the far right, is what a spinal cord lesion looks like in multiple sclerosis. So it's very short and kind of ovoid appearance there. Now, back in the 80s, when we were first getting MRIs, the neurologists were so nerdy then, they called these UBOs, unidentified bright objects, because they didn't completely know what they were yet. And the thing is I showed you guys very classic MS, but people can get spots in their brain for lots of reasons. We get spots as we're aging. People who smoke get spots. People with high blood pressure, sugar problems, migraine headache. All of them can leave little spots in the brain. So that's why it's so important that clinicians look at the MRIs, because radiologists are fantastic, but they don't get that human history plus that picture. So people get scared. They see weird words on their MRIs, and that causes a lot of angst. But we need to actually physically look at the images and talk to the person who has those images to really make the right diagnosis for the patient. So this set of McDonald's criteria also delved more into our advanced MRI technology, and it is advancing rapidly, even from the time I've been in practice. And so we've actually gotten 2 new types of findings that are highly specific, which means it is very likely that somebody has multiple sclerosis if we find these on their MRI. One of them is called a central vein sign. And that's this picture over here. And what a central vein sign means is that right in the middle there, you see these little holes. And that is a vein. And that's because of how the immune system has gone awry. And all those immune cells just float on up, and they go into the ventricles, and then they inflame out to the ventricle, outside of the ventricle to the periventricular space. And they go up these little veins. Well, that vein's now overworked in an MS lesion, so now it becomes a central vein in the middle of the lesion, and we can actually see it. And then there's another thing called perimagnetic rim lesions. A lot of big kind of scary words for what's really just a smoldering lesion. So it's that pothole that just kind of keeps expanding and doesn't ever really stop expanding. That's what a perimagnetic rim lesion means. Also very specific for MS. And there can be a couple different types on MRIs. So this one down here on this white arrow is very bright. You see a little bit of bright here and a little less bright there, and that is the inflammation continuing to smolder outside of that lesion and continuously expand it. And you see more subtle up on the 2 dotted arrows, that is more subtle perimagnetic rim lesions. And so this is actually a spot where I do believe that AI will help us in multiple sclerosis care, because the size of these lesions and the paramagnetic rim lesions and the expansion of these lesions can actually be very hard to see year to year on comparing one MRI to another, seeing 1 to 2 millimeter differences. But AI can actually see this a little bit better than our own eyes can see it. So that combination of a clinician plus AI can be helpful. So lumbar punctures. I say this word to any of my patients and their first face is very scary. Lumbar punctures are still important in the diagnosis of multiple sclerosis and still often needed depending on other data that's available, history and MRIs. And what it really does is helps us differentiate multiple sclerosis from other conditions that can also leave white spots in the brain or the spinal cord. So there's two things that we really look for on that lumbar puncture. We look for something called oligoclonal bands. And those are markers of inflammation. And we look for at least what we call 2 unique, which means that they are in just the spinal fluid, not also in the blood. Now, this test has been around for many, many years, and it's a very solid test. It just takes forever to result. It takes about 7 days, which is now forever in medicine. So there's also a newer one that can often be done locally and not have to get sent out to a different state or a different hospital to get run, and that's called kappa-free light chains. And this is considered a new, faster biomarker that we get in the spinal fluid, and that's highly specific for multiple sclerosis if it's above 6.1. And so that is what you'll start to see on some younger, newer lumbar punctures. You might see that instead of oligoclonal bands. And that is another thing that was throughout the McDonald's criteria, is ensuring that we use the right paraclinical testing, which means the right lumbar puncture results and help us get that right diagnosis. So an earlier diagnosis is encouraged with the updated McDonald's criteria from 2024, but it's got some safeguards. Number one goal of somebody like me or any of your clinicians is to make sure that you've ruled out mimickers of multiple sclerosis. I need to make sure that I've looked for things like migraine causing some of those white matter lesions, high blood pressure, what we call vascular disease, small little strokes that have left no symptoms, and even other inflammatory conditions that are paired, kind of cousins to multiple sclerosis, but different diseases and different treatments. And that would be NMOSD, which is neuromyelitis optica spectrum disorder. Really big, scary words. I told you we were nerdy. And then MOGAD, which is myelin oligodendrocyte glycoprotein associated disorder. So those are things that really like to attack the optic nerve and the spinal cord. And so we need to test for these when it's appropriate when we look at somebody's history and MRIs. Likewise, children and older adults can still be all diagnosed with the same McDonald's criteria, but we need to take another step of safeguarding them to make sure that they have the right diagnosis. So just making sure that you've really done the good workup on a patient to ensure that this is multiple sclerosis before starting them on treatment. All right, questions? That was a lot of information I threw at you very quickly. Yes.
You mentioned advances in MRI technology recently. Are those advances out in the community setting yet, or are they more at a larger university or an MS-specific treatment center?
All of the above. So the question was about advanced MRI techniques and how readily available are they. So I'm picky. I like my what's called a 3 Tesla. That's a higher magnet in the MRI, and there are actually many places in Michigan that have a 3 Tesla. I'm almost positive Munson has at least one, right? Yep, Munson has at least one 3T MRI. And when I start to look at things like the spinal cord, that things can look very small, I like really good pictures. So absolutely out in the community, right here in Traverse City, down in Kalamazoo, Grand Rapids, Detroit, Saginaw has a 3T. I don't remember about Bay City and Midland. But a lot of people have 3Ts. Now there's even more advanced MRIs called a 7T, so double and a half, whatever that math works out to be. And the closest one to us is Cleveland, and it's used for research only. I think Chicago's getting one now too. So there's that. And then you can see a central vein sign on a 3T MRI. You could even potentially see it on a lower one called a 1.5. It's just also about the right person looking at those images and really having a keen eye. I bored you guys that much?
Oh,
Yes.
if I may ask a follow-up.
I have a question.
Please.
I've probably asked you this before. The different types of MS? Is there one that is better, or what's going on there?
So MS is MS is MS. So MS, we have this joke in neurology and definitely in fellowship, MS fellowship training, that if you've seen one person with MS, you've seen one person with MS, because everybody's story and everybody's journey is different. So there is no good or bad MS. It's your MS, and it's ensuring that the treatment is right for you. Now, many years ago, we didn't have anything in terms of medications that helped modulate the immune system to help protect against progressive symptomology of that concrete underneath falling apart. But as of 2017, we do have medications, and we have several coming down the pipeline that also help protect that. I also know that in earlier MS, if I protect against potholes, if I protect against inflammation, I also protect against that concrete falling apart later in life, so that progressive type disease. So there's no good or bad, it just is. Tammy, then Mark.
You mentioned about, and it's amazing that we've gotten diagnosis sooner, 4 years to 1 year. Do you think we'll get it even quicker than that? I know it's something that the MS Society wants, but how realistic is that?
I think it's pretty realistic. My current record from time of diagnosis to time of initiation of treatment is 7 days. And that was my first year out of fellowship. So he got his MRI, saw me the next day. So he had symptoms for about a week and a half. Got his MRI, saw me the next day. I made the diagnosis, and he was on treatment before Thanksgiving. So the goal is that if somebody presents to the hospital and ends up in the hospital with an MS attack, which sometimes happens your very first MS event, is that if we get the MRIs inpatient and we get that lumbar puncture with those kappa-free light chains that return in 24 to 48 hours, we can be making that diagnosis in under a week. And then that helps us get treatment initiated sooner. So yes, I do think that we will get below 1 year. Maybe even to just a couple months.
Yeah, I would say a lot of that is the education of primary care providers, and more medical schools require neurology experience for their students. Because if you go to your primary care provider with a kind of atypical, this happened, should I pay attention to it, and they tell you not to because they're not aware, then that's a delay. And so I think that education of those students really is moving things in the right direction as well.
Absolutely. So many of our medical schools here in the state of Michigan do require neurology. But even at that, like primary care, now at the American Family Physicians Conference, they're talking about multiple sclerosis. Because even when I was in training, it would be, oh, somebody after they deliver a baby has some numbness of an arm. Oh, it's probably a peripheral nerve injury. Because like I said, you can have the same symptoms, but the different part of your nervous system be impacted. And MS attacks the brain and the spinal cord, which is your central nervous system. But things like carpal tunnel, that's a peripheral nerve injury, totally different part of your nervous system. And so somebody with bladder problems and a numb arm or a numb leg, just kind of, oh, you had a couple babies, oh, you've got a peripheral nerve injury. The heightened awareness is now to at least consider multiple sclerosis, especially in those females between 20 and 50. Because like most autoimmune disease, MS is more common in women. Although still happens in men, so please do not ever blow them off. It definitely happens in men. And I have heard crazy things as a neurologist. I've had new male diagnoses that have been told that no, men don't get MS. Men do get MS. And so we're unpacking and undoing medical misinformation. And on that note of medical misinformation, stick to like websites like the National MS Society. Wide range of great information, reliable information, medically sound information. Other websites, Reddit, we don't know what's really on there. So if you want to know about your diagnosis, seek out things like the MS website or even some of our hospital-based websites. Cleveland Clinic has a great MS center and a great website for multiple sclerosis patients. University of California, San Francisco, Mayo, Harvard, they all have really good, reliable sites. The MS Society even has videos on now. I was on it earlier. making sure I knew exactly what was on there before I told you guys to go there, because I hadn't looked at it in a month or two. So they actually have some great stuff on the McDonald's criteria, the updated, the link to the articles for the new McDonald's criteria. And with the new McDonald's criteria, we have a partner study, partner guideline recommendations about how do we MRI people who have MS. What is the right protocol, order of images for the hospital to use or the MRI center to use? What are we looking for? Like things like those central veins and those paramagnetic rim lesions, how often they should be done, because I get to decide that as your clinician, not your insurance company. And when I think you need one, we have that argument and we have these guidelines for that reason. And what do we do moving forward with these MRIs? So those two guideline recommendations came in tandem of each other. But really detailed and nitty-gritty to get in here tonight. Yes.
Are there implications with the new criteria for diagnosis? Implications for all the folks out there already diagnosed with multiple sclerosis?
Not that I'm aware of. So I had to think about the question. So the question was, with the 2024 guidelines, will there be implications to anybody who's already diagnosed as multiple sclerosis? And as I was thinking through it, I don't see any way that somebody who met previous alliterations or previous criteria would not meet this one now. Now, I will tell you, when you come to somebody like me as an MS specialist, I will tell you my very first job is to make sure that the diagnosis is right. So even if you come to me with a 15-year diagnosis, I might go back and double check things if I see something that just doesn't settle right with me, and to make sure that it's not one of those other diseases or conditions that we treat differently than MS. So I sometimes rattle people a little bit, but my number one job is making sure that the diagnosis is right and that I'm treating the right condition. Yes.
We have a question from one of our people who is joining us online. And they said they just had their first event, which was double vision, which led to MRIs that showed indicators that led to treatment for them in the hospital with steroids and additional MRIs. They're wondering if they're going to have lumbar testing or other testing to confirm before they start treatment. Basically, they're still getting referred. They just got referred today, so they're going to be making their appointment and are wondering if they're going to be talking treatment at that appointment or if they're still going to be talking about confirmation.
So I will tell you how I would more than likely handle a patient in that scenario, because having not seen those those MRIs myself, I'll answer it more broadly. So a first visit with a neurologist or any clinician who manages multiple sclerosis is often making sure that the diagnosis is correct and making sure that no additional treatment is needed. So if it's a classic event a classic MS event, which double vision is considered a classic demyelinating event, if the MRIs look classic for multiple sclerosis, they may or may not need a lumbar puncture depending on what else those MRIs show. Treatments is a whole nother discussion. So there's a whole bunch of safety things that we look at with treatment. So often at those first visits, we're getting what we call safety labs to talk about which treatment options might be best. Because we don't just have you come into the office, say, here are all of the treatments for MS. Here's 24 of them. Go research them and you tell me what you want to be on. We have a conversation about what fits into somebody's lifestyle. What can they do? Can they remember to take pills every day? Can they give themselves a shot? Can they go to an infusion center? And what is safe for them? As we modulate the immune system, there are some risks. And so I don't want to take any undue risks that I need to and put somebody at risk of a different type of infection. And all of those things go into consideration of picking the right treatment for the right patient. They're going to travel. Like I've had people move to South Africa on me. Like there's so many things that I can help people with MS live their very best life. If you want to have children, we can figure that out. You want to keep working, we can figure that out to the best of our ability. And, again, if you see one patient with MS, you see one patient with MS because it's everybody's individual journey. Any more online questions? Okay. All right,
Thank you.
Dr. Walsh, thank you very much. Thank you so much for your presentation. And the question from the person online did remind me that I neglected to welcome them when we first convened this meeting. And that's certainly one of the big advantages of Traverse Area District Library being our host, is that one of the challenges for Northern Michigan, of course, is travel, particularly this time of year, and having folks having this program, available to folks remotely is a big plus. So welcome to those folks as well. Next up is Dr. Austin. Dr. Austin is from Munson Medical Center here in Traverse City. She is the director of their medical side of their neuroscience program, which just started. She's also an MSU product with her DO and her residency in neurology from MSU, and then a fellowship in neurophysiology. So thank you so much, Dr. Austin. We're really excited to have you here from Munson, and you're going to talk a little bit about some new things going on here in Northern Michigan.
Yeah, thank you so much. So Mark in the group asked me just to come and say kind of, what does Munson have going on right now? I thought I was actually going before Dr. Walsh to be the prelude, but I won't keep you long. They're going to get my presentation up. And mostly I wanted to let you know that it's a lot different than it was a few years ago. So we have a lot of, the biggest thing on this screen that's different, I think, is the available thing. There were lots of years where you would go to your primary care doctor and they'd say, well, we can't get you into neurology in Traverse City for 2 years, so we'll send you somewhere else. And that's changed a lot. I want you all to see this picture because I'm going to talk about the artist in a minute too. So this is our group, and actually since we took this, I took this from our website. Since we took this picture, we've added 2 more physicians. And so we have a lot of access now. We have a lot of broad specialty ranges. We have people, so in particular, yes. This is Dr. Pangborn, I'm going to talk about in a second, who has a specialization in MS. We have Dr. Frazee and Susan Corson, who's right here, who specialize in headache and migraine. Dr. Zendler, myself, and Amanda Gross specialize in epilepsy. And then Dr. Lee specializes in stroke. She's right here. And then most of us also see, and Dr. Fanta is our newest neurologist who's going to Manistee as well, so helping those patients farther out. And most of us see general neurology too, so other diagnoses, so your family members who might have numbness from neuropathy or other things, we see that too. And so Dr. Pangborn came to us. Actually, she just was in practicing for the last few years in Milwaukee, Wisconsin, where she had a significant MS population, and that was her kind of specialty interest. And she's a wonderful clinician, has a wonderful bedside manner, and is just very thorough. She's one of the most thorough neurologists in general. We're a group of very, as Dr. Walsh said, we like to recheck diagnoses, we like to read through records, we like to make sure that we have our own opinion, and Dr. Pangborn is excellent at this. So she is our new MS. She was unable to come today. She has 3 small children, but she's the person we have here in town, in addition to all of us who see MS. So we're not MS fellowship trained. Dr. Walsh is MS fellowship trained, but myself and Dr. Lee and Dr. Pollack up there, we've seen MS for years. We treat MS and are comfortable doing so. But I wanted to point this out too. When I was looking for my presentation, I was looking for interesting artwork, and this was a lady who has MS, and then she takes her image, these are her MRIs, and puts them on like a metal plate and then makes them into artwork. And she celebrates a lot about celebrating the flawed body is one of, she's like a TED Talk about this and stuff too. So I just wanted to share her website too, because I found this piece of art and found it fantastic. And that's really all I have. So what questions do you guys have?
Go back one slide.
Oh, sorry. Yeah, it was fantastic. Yeah, it was really great. I was like, I'm going to use this picture. And I said, I need to, then cite her. And then I looked at her citation, and it was just this really interesting journey of this woman with MS. And she now is in a wheelchair and can't use her hands. And so she has a studio assistant who helps her do things. but her work is beautiful. There's a bunch of really interesting, and again, based on her images and stuff. There were things, Dr. Walsh, there were things I was like, these need to be up on our clinic. Our clinic has terrible art, though, I will say. I apologize for that. So what questions can I answer to anyone about Munson, about what we have, our availability, our knowledge, anything like that? Yes.
With some more resources now that you,
Yes.
that you have, and the resources that obviously have been dedicated by Munson to neurosciences in general, do you anticipate a research component?
So we do have some research in neurosciences. We do stroke, primarily we do stroke research. We are a comprehensive stroke center, and so we do stroke research. We are planning to expand our research capabilities, and we are working on that some. So yes, I would say. And also, as you said, the kind of the resources dedicated toward neurosciences, when we were talking about imaging earlier, we do have neuroradiologists. So we actually have 3 neuroradiologists. So that's where we have that partnership. We have people who really go through the expertise to look for these subtle signs, for us to have someone to talk to about the imaging, and that's always very helpful too. We're really lucky in a community hospital to have that resource. Yes.
So we do have a question online, and you had mentioned earlier that it used to take a year to get in to see someone, and so they're wondering what is that waiting time now? For example, for the new Dr. Pangborn.
Yes, so Dr. Pangborn's schedule filled up very quickly because we had a doctor retire at the same time, so she took over a lot of patients. But Dr. Pang, I think so we have like a metric actually that we look at in medical practice is called the third next new. So our third next new patient on average in our practice is, I think, 60 days, and I'm not sure what Dr. Pangborn is scheduling. But if the person in the chat's the one who just was referred, if they're comfortable sharing their name to you and you can give it to me, I can see what we can do to get them expedited. Yeah.
You don't have to be referred. You can just call.
You do have to have a referral from someone, so primary care or your gynecologist or you do have to have a referral from somewhere. Yeah, but most doctors will refer. If you didn't have a primary care for some reason, they went, or your other neurologist, like if you're seeing someone downstate, I get referrals for epilepsy patients from other neurologists. I'm sure Dr. Walsh does the same. Like if, like I would send to Dr. Walsh, but even the specialist will sometimes send back up, say, you're stable, you're doing great. Like you don't need to drive down here to see me anymore. Like we'll get you up there. So. Yeah.
Absolutely. And we do a lot of that. There's not enough multiple sclerosis specialists to go around in the country. So I partner with people up here at Munson. I have people get their treatment or their MRIs up here. We do that for all neurology specialties. So another thing that I want to encourage is that a doctor or any clinician does not get offended if you want to see somebody more locally. Most of us want the very best for you and what works for your life, and driving 5 hours to see a doctor does not make sense for everybody if you have a resource locally.
So just to summarize what Dr. Walsh said, she was saying that, yes, like oftentimes people are seeing the subspecialist. So Dr. Walsh is a fellowship trained subspecialist in MS, which we do not have. Dr. Pangborn is not fellowship trained. It has been her focus, and she is that, but she's not fellowship trained. But lots of times we get there, we get the basic diagnosis, lots of questions get answered, and then you don't have to drive the 5 hours. And Dr. Walsh said nobody is offended if you want to seek care closer to home. And I would say on our end, nobody is offended if you say, I'd like to go see these people, and I want to keep you too, but I want to go see these people, or I don't want to keep you, and I want to go see these people. Like, that's all fine. And I think nobody should be offended. I had a patient who I see for epilepsy, for seizures, and I'd seen for a long time. He's an older gentleman, and he said, you might be mad, but, my daughter has epilepsy too, and she wants me to go see her neurologist at the University of Chicago. And I was like, well, I'm not mad at all. Like, I think we should do this. I said, here's the reason. Either I learned something new, you come back to me and you say, this fancy doctor at the University of Chicago said this, and I learned something new that I then am better at treating somebody else, or we just get a confirmation that what we're doing is right. But then the funny thing is he came back. I saw him the next visit. We were doing the visit, and at the end, he said, you didn't ask me about that visit. And I said, I didn't realize if you'd had it, And he goes,
she was just like you. She kind of looked like you. She was wearing the same shoes you wear, and she asked the same questions, and she said all the same things. And I said, well, we do go to training programs that make us all kind of the same. And so you should always get a second opinion if you want it. And if you've gotten your second opinion and it's far away, like Dr. Walsh, and you want to come back to your community, there's no bad blood between us all. So. Yeah, but you do need a referral to get to us through the door initially. Yeah. So, yeah.
Questions?
All right.
Thank you so much. So I just wanted to reiterate, thank you.
I'll trade you for my phone.
Yeah, you're going to want that. So I've lived here in Traverse City for 29 years, and I think for that entire time, there's been a shortage of neurologists. And so this commitment of resources is a big sea change for Northern Michigan, and I think that that's a real change for the positive. In advertising this program, I took a look. There's no full-time neurologist now in Petoskey. There's no full-time neurologist in Alpena. And so these resources are not as available in many parts of Northern Michigan. And we didn't call our MS group the Traverse City chapter. We called it the Northern Michigan chapter because we want this to be a little broader. And Munson having neuroradiology and some of these other improved capabilities is a big sea change, and we're very happy to be partnering with them. That brings us to our last speaker. And Jenna, thank you so much for being patient. Jenna Stoddard, nurse practitioner from Novella Specialty Clinic, is joining us. She has her BSN from Grand Valley, and then her MSN from Morehead State, University of Kentucky, and 8 years of clinical experience. And we're very glad to have you here. And she does not have slides, but going to talk a little bit about the role of the nurse practitioner in your practice with MS patients. Thank you so much for coming.
So I'm Jenna Stoddard. I work at Novello Specialty Clinics in the neurology group. We're all neurology now. And I've been there just shy of 2 years. It's myself there, Alicia Hill, who's our PA. She's also attending today, and Dr. Cornelius Robins. And so we see general neurology. I'll say none of us are, specialty trained in MS. We see everything. Dr. Robins in particular is fellowship trained in movement disorders. But again, we see everything there. Our role as far as mid-levels or nurse practitioners or PAs in the facility is to help supplement the care that we're able to provide also with the physicians. So often you will see us either as your initial visit or as a subsequent follow-up, and then often, especially when it comes to MS and some more of these complex diagnoses, we are alternating between ourselves and the physician in the group. So that way we can make sure that you have multiple points of contact. We do a lot as far as imaging with Munson, as well as Novello Imaging, which is an independent imaging facility. But just like Dr. Walsh had mentioned, with MS, no two people are alike. They're very much like snowflakes, so everyone is going to present differently. Sometimes there's very overt symptoms, and sometimes they are more mild symptoms that no one can really make sense of. And education with primary cares is a big thing for us, trying to make sure that we're getting referrals in a timely manner and not just blowing off symptoms that may seem mild. I know plenty of people that maybe had presented with mild symptoms for a long time. Maybe they kind of waxed and waned. Maybe a brain MRI was done, but there was no lesion. So it was, you have no lesion, so you don't have MS. And that's not always the case. A lot of times in RN, we're doing brain and cervical spine. So that way we're checking more in the spinal cord to see if there's other lesions otherwise. And then we have the capabilities of doing a lumbar puncture because you won't always have those lesions that are present that gives you this visual of MS. So again, on our end, we're helping supplement things. We see a little bit of everything, but we're there to help facilitate diagnosis and treatment and any of the needs that you have. I don't really have a whole lot more for you though, but if you have any questions, please feel free to ask. Yeah, go ahead.
May I inquire about your typical waiting time?
Sure.
Patients, please.
I don't know where we're at with things right now. Usually it's fairly quick to get in with myself and Alicia. So usually within a few weeks, we could get someone established, and then getting back in with Dr. Robins. Again, we've kind of got some scheduling templates, so we leave some availability for him for new consultations or for follow-ups. But usually with him, it's if it's a brand new consult, usually a couple of months there. But again, usually quicker with us. So often he'll see patients at scheduled time frames, and then Alicia and I will see them in between, especially if there's new acute issues. But usually not too long.
It's coming to Jenna or I, and it's a case where it's not a classic presentation or a classic radiology finding of MS. We're often running those cases by Dr. Robins that same day. So it's not like you have to wait 3 months or so for Dr. Robins' opinion. Like, you'll get his opinion that same day, even though he didn't actually see you and evaluate you in clinic. And sometimes he does, depending on the case. He will also step in and see some of our patients too that same day. But you'll get kind of the collaboration the first day that you see us.
So for anyone that's online, what Alicia had said is that even if you're seeing us initially, especially if you don't have the classic symptoms or, the picture-esque MS diagnosis, Dr. Robins, we literally work shoulder to shoulder with them. So a lot of these cases we're, stepping out of the room, or after the initial consultation, we're discussing with him further, and then contacting the patient if there's other recommendations or other findings that we need to address that weren't completely obvious to us. But we work very closely with them. So usually with some of these newer complex cases, we're not evaluating them completely on our own. Like, we'll look at the images together and make sure that we're understanding the greater picture of everything. And even in the interim, if you had seen Alicia and I first, and maybe we can't get you in with Dr. Robins for 3 months, additional testing that's required in the meantime. If we need to work things up further, get additional imaging or further labs, we can help take care of that in the meantime. So that way you're not just waiting to see the physician to get all this done. So again, that's where our collaboration with the physician comes into play. So that way we can make sure we have the appropriate tests ordered for you. And that way we have that comprehensive data, so we can confirm that diagnosis, or when you see him, then he has all the information that he needs to make sure we give you an accurate diagnosis.
In neurology now, a lot of the treatments are infusions, not just with MS. So is infusion therapy part of what you offer?
Yep. So we don't do infusion therapy specifically in our clinic itself. We refer out to the community, and certainly we have because there's such limited neurology facilities in northern Michigan, we get a variety of people, anywhere from the UP, and I find that Grand Rapids is kind of the cutoff point for most people. They're at that point, Big Rapids or Grand Rapids, you're either going to go north or south at that point. So the majority of northern Michigan is going to come to either Munson or Novello here. And so there are a wide range of infusion facilities and also home infusions. And there's a big push towards home infusions for the infusions that are safe to perform at home. And so there are a lot of home infusion companies that we can go through, and part of it depends on insurance, part of it depends on patient preference and what drugs are being used. So there are a lot of options with that for infusions, and we have a lot of great local options for it too. Yeah. Any other questions? Well, thank you for the opportunity. It was nice to meet everyone.
Thank you very much.
Jenna and Alicia as well, thank you both for taking time out of your schedules tonight. We're happy Novella's specialty clinic is here to help MS patients. That's our bias, are those MS patients. So just to wrap things up, I did want to introduce one other very important person on our Northern Michigan Community Council, and that's Larry. Larry, would you please come up? And he is our fearless leader of our local support group. And again, one of the things that MS Society really prides itself in are resources, good quality resources. And we got a shout out from two of our three speakers on the quality of those resources through the MS Society. He's another one. Thank you.
Takes me a while to get up here. You'll have to forgive me. But as one of the other speakers acknowledged that other sexes other than females get MS, I'm evidence of that truth. I've got primary progressive MS, and I was diagnosed about 15 or so years ago. And I'm lucky enough that I'm able to be in the support group and be the leader of the support group. I started out going to the support group in town when a lady named Karen Bailey ran the group. And Karen had to leave her position because she wound up taking care of her granddaughter for her daughter who was going through a divorce. And Karen had MS, and then dealing with a 2-year-old, boy, that would do me in faster than my MS is. But I'm the current leader. We do get some men who come to our support group. Most of the people that do show up are women. We meet the third Wednesday of the month at the Traverse City Big Boy on Division across from Myers. We meet at 4 o'clock. I try to send out emails to everybody to remind them of the meeting time. I'm also on Facebook. I put posting on Facebook to give you a reminder to come. Very informal. Most of the people who do attend have been attending for years, which is a good thing. And I'm not a doctor, but I'm starting to know the different medicines, and we kind of kept it between ourselves about what has worked for us and what hasn't worked for us, and the different medicines and things like that. So you do pick up things from other of the MS people who are in the group, and you learn some things, and you can complain to each other, and we don't complain about the doctors, honestly.
Yes.
We only complain a little bit. How's that? That sound better? But no, it's a good group. Everybody gets along, and we share our experiences, and we don't kibitz with the doctors and complain about them. We're nice people. But if you want to come, you can always join us on the third Wednesday of the month at the Big Boys. And if you want to have coffee or pie or just cold glass of water, it's fine. We always sit in the back of the room and pull tables together depending on who shows up. And it's a wonderful event. And I enjoy it, and it's fun to meet people and talk to them. And I want to make up for Mark, make up from the sense that I see my friend in the background, and I'll mention her first, Sherry Fenton. She's in our group, in the Northern Michigan group. So I don't want you to feel offended that I'm not mentioning you in the group. So I think I've covered all my bases. And if anybody wants to come, please come. I have a member in the group, Amy, is here today, and I appreciate that she comes, and she even RSVPs that she's coming. I have 1 or 2 people that RSVP and tell me they're coming ahead of time, but most of my group doesn't. But that's okay, because I know you're coming. So, but please come. I enjoy it, and I think everybody in our group enjoys it. So, non-committal, but please come. Thank you.
Thank you. Thank you. Just to wrap things up, I think one thing that Larry mentioned stuck with me, and that he said, boy, we have some regulars. We have some long-term support group members. And that tells me that it's worth those folks' time and it's worth the effort to get there. It's valuable. And you bring great value with your support group, Larry, and we are all grateful for that. I want to thank all three of our speakers for doing such a fabulous job. I want to thank Melissa and her crew at Traverse Area District Library for hosting and broadcasting tonight. The Northern Michigan Community Council is not yet complete. So if you or anyone you know or loved one who may be interested in joining our crew, we could use it. And yes.
What is the purpose of the council? What
Thank you.
resources do you
Thank
have?
you. That is what you call like just absolute opening. So our purpose is to improve the lives of patients living with multiple sclerosis in Northern Michigan. That's it. And people living with MS in Northern Michigan is the reason we exist and who we try to serve first and foremost. We're a relatively new organization, a couple of years in, and so at this point we're trying to raise awareness. We're partnering with various people, Munson, Novello, Traverse Area District Library. Right now our purpose is raising awareness about MS and about ourselves in the short term. We also will be doing some fundraising, which leads me to the community events that are available in 2026. There's a list on the table. One of those things is right here in Traverse City, and that's called the Walk MS event. June 20th, I believe, is the correct date for this next year's program. And I hope to see everyone there. It's a lovely event. We always have really nice weather. And it's a really great, again, community awareness event for patients and their loved ones to participate in. So if you haven't done a Walk MS, I would strongly encourage you to attend ours in June. And then there are 2 Bike MS fundraiser events, which Patty and I are particularly interested in because we're cyclists. Sort of one on the east side of the state, one on the west side of the state, and those are listed on the sheet as well. So again, to help folks living with MS in Northern Michigan, that's why we started our chapter. Tammy, when Patty and I were just doing some fundraising, Tammy Willis from the Michigan, director of Michigan said, you know, MS resources don't get utilized in Northern Michigan compared to Grand Rapids, Detroit, Tri-Cities area. That's not right. That shouldn't be. And so that's one of the things we're trying to change with our chapter, is to utilize those resources. MS ends with us, and I love the fact that the MS Society is very plain about their goals, and that is end MS in our lifetime. And that's very exciting. So that's a larger goal for the MS Society that segues very nicely in with our smaller goal for our local Northern Michigan chapter. Thanks again, everyone. Please be careful on your way home. And I really appreciate everyone's attendance as well as online. Thanks so much.